Formally, we are going to start our session now. Very good afternoon to all the ladies and gentlemen out here. At the outset, I thank the AIOC Organizing Committee, the President, Sir, Secretary Ma'am, Dr. Partha, all my panelists, Dr. Grover Sir, and Dr. Dilpreet, Dr. Anaga, Dr. Sudhir Srivastav Sir, Dr. Manish Mahindra, and all the audience who has spared their time here. I welcome you all in this session. What exactly this session means to us? Actually, many times we see that we do a beautiful surgery or we intend to give very good results, but despite of the best of efforts, something misses out, and we land up in a situation when we have a good surgical outcome but an unhappy patient in the post-op phase. So what are those things that we miss out? So better to have learning from the experiences of ours, that what mistakes we have done in past and what mistakes now we are going to show that we did, so as to make us wiser to have better post-op results in future. So that is the whole case and the whole course all about. Very unfortunate event happened with our chief instructor, Dr. Dilpreet Singh, and so we'll be missing him today. He is not able to log in, and his talk has been very, at the very last moment. Now, Dr. Sudhir has consented to take up, and he will be giving his inputs on his topic. So, thank you, Sudhir sir, for the same. And we are blessed to have Dr. A.K. Grover with us. He is chairman Gangaram Hospital, Delhi, and doesn't need any introduction. And we are blessed to have him today with us. He will be joining very soon. Dr. Dilpreet is a famous refractive and cataract surgeon from Uttar Pradesh, Kanpur, and he has a roaring practice and is MD and chairman of Angel Eyes Institute of Ophthalmology. Dr. Sudhir Srivastav needs no introduction. He is a famous face at AIOC. He is a pioneer refractive and cataract surgeon from Lucknow and is MD and chairman of Sun Eye Hospital and has presentations to his credit from across the globe. And Dr. Anaga with us is the bright and shining face of ARC and AIOC, and he is all set here to give her presentation from Mumbai. Dr. Manish Mahindra, often we see him on the platforms of AAO and ASCRS and ESCRS. Today we will find him in India. Thanks to you, sir, to have a talk from India. You are an international star, I know. So it's great to have you here, sir. And myself from Kanpur, I am a consultant ophthalmologist working at Regency Hospital, Kanpur. So without taking any much more time, I would like to share my screen and start off with my own presentation on what clinical things I miss in my workup so as to have an unhappy patient post-operatively. This is what I am going to talk about. Is my screen visible?
Yes.
Okay,
Yes.
that's great. So now I'm going to talk about what I miss in my workup and in my OPD that gave me an unhappy post-op patient. Sometimes, let's see it by a case scenario. A patient came to me a few years back when in the left eye the patient had immature cataract with a normal slit lamp examination, nothing in fundus, with an Iul power calculated of 24.5 diopters. The right eye was pseudophakic 6x6 N6 vision dot on and a multifocal IOL in C2. We didn't had any of the records available with the patient, and the fundus was normal. So the other eye was challenged to us and we took it up. And my phacoemulsification was done with multifocal IOL. This was the outcome dot on. I was happy and yes, good chirping face. But then in the post-op, what I found that the patient is just 618 and N10. Then I was told that the patient is not improving. The eye was quite nice. Then what happened? Then the faces were gloomy. And then I literally pulled my hair that was it an amblyopia I dealt with. So what exactly happened? The IOL power was 24.5. No details from the other eye. I put it an multifocal IOL without any counseling, no more discussions. So what message was given by this case? That if you don't have the biometry or the refraction details available for the other eye, then you must raise a red flag if you have a hypermetropic reading in this very eye. Or even a very high myopic if you are getting, then also a red flag sign is to be raised and the issue to be discussed with the patient pre-operatively. So now you can't compare the result with the other eye despite doing a perfect surgery. Another case, a patient was worked up by an optometrist, seen by me under dilated state. All readings were under physiological limits. Huge OPD rush out there. Finally, patient was taken up with a premium IOL and nicely average good surgery done. IOL in bag, everything fine. But then in post-op, again the patient was 618, not improving further. What happened? The eye was quiet. And oh my Joe, what is this? The patient had squint. I had a huge black screen in front of my slit lamp. I didn't ever see the whole face. I just saw the eye. How busy I was. I just ignored this deviated eye and I took it up. And that very day I took a lesson that yes, torchlight examination is must before cataract surgery. And yes, we had a patient right in this COVID era coming in post-op phase, always on the very second or third day coming that nothing has been done in my eye, the whole eye is spoiled, whole day I have watering, whole day I have grittiness, my hand is always there on my eye. Despite doing the best of surgery and 6/6 vision, I used to label him functional. And the whole staff used to get irritated as the patient used to walk in the waiting area and used to counsel others also what the doctor has done into my eye. That was a huge issue. And yes, I do admit that there was keratitis in the post-op phase and frequent use of prednisolone was done in the post-op period. But then, careful examination again retrospectively revealed that patient had severe dry eyes. And yes, this was the corneal staining. This was the meibomian gland state. So it would have been really wise if I would have really taken up this case before cataract surgery, given some treatment for meibomyitis, some lubricants before taking her up for surgery. That was my mistake. I should have delayed the surgery. I really took it up very fast and operated, and despite doing a good surgery, there wasn't a functionally good outcome in the patient. Now, there are mad cat surprises. See a cataract of this kind, Morganian, dense cataract, PR accurate, PL positive, other eye immature cataract, IOP fine, fundus not visible. Other eye also hazy, but yes, it was normal. Patient was again seen under dilated state by me. There was no subluxation. I made sure that there is no pseudo exfoliation. And yes, I was intelligent. I ordered a B scan. The B scan was normal. Yes. Now there was a dilemma whether I should go for a phaco or I should do an SI case. But still, a heroic surgeon. Yes, I will do a phaco. And then, by God's grace, it went uneventful, nice and good. While doing surgery, what is this? I saw a yak PI. Just beneath my incision, I could see a yak PI. This was never seen before. What is this? What am I dealing with? And then in post-op phase, patient was finger counting 2 meters, cornea clear, nothing wrong. But then I knew something is going to be there, and this was the state. And this fundus speaks on itself that I miss this yak PI patient never told. They are just mute. Many times they just don't speak. The attendants shower their things on them, and especially if something has been done on them, they will hide. So we have to be interrogative. More and more direct questions have to be there. More careful examination, undilated state should be there. Lift up the eyelid and see if anything is hidden over there, and then take the patient up for surgery. A very interesting case. Patient came, this was a school going child with some cataract, history of a wooden stick hitting the eye and almost total cataract out there. He was uncooperative on slit lamp, just squeezing the eye and going back. Somehow I throwed the light from indirect and saw that yes, I can see a pink red glow. There is nothing wrong. I just could see the disc also. So nothing more was done, and yes, the patient was counseled and patient was taken up for a good monofocal IOL surgery. Patient had this time less of even dilatation, but then yes, workup was done, patient was taken up, and surgery was finally done. This was the picture I saw. See, there was a hole in iris. What was this? Was it an entry wound I am dealing with? I don't know. Then, after nucleotomy, what I saw? A small PC tear. Was it pre-existing or it happened just now? I was not sure. Things are moving fast on the OT table. Then, I am a talented surgeon. Yes, I will go for IOL in back over the PC tear. Yes, somehow I managed. Yes, I inserted the IOL in the bag as you could see over the PC tear. Now, In post-op, again the patient was 660. Attendants were unhappy. The child was not reading further. And now see the fundus. By Jove. From where has this come? The huge foreign body. It was like a rocket. It went into the eye, the pierced the lens through and through, and then it stuck just adjacent to the macula. Oh no, I should have investigated more. Really, it was my casual attitude, or I was so confident with my indirect ophthalmoscopy that I didn't take up for V scan or whatnot. Definitely, the cataract surgery was then also required, but maybe IOL was not required at that stage, because now how to take out this foreign body? You have to have a route for that. Anyways, retinal issues are very common. Few years ago, I operated a retired scientist from IIPR here in Kanpur. Uneventful surgery, nicely done. Even I was happy, smiling. Pre-op vision was 660, and yes, things went fine. After a week or so, when the patient said, "No, my vision is not very good," and then I could see that the best corrected vision was just 612 and N10. He was not improving further. The eye was spoiled. So what went wrong? I just did an OCT. Oh by God. I just missed a small pseudomacular hole behind a grade 3 cataract. This was expected in a 90-day examination of a 70-year-old man. I might have missed it, yes, but you know what happened? Patient sued me. Believe me, I received a letter from a lawyer. Oh no. Oh yes, my dear friends. Patient sued me and I had to be replying to those letters. People are ruthless. So now a big question comes. Should an OCT macular scan be done for all the cataract patients preoperatively? I don't know what the consensus and guidelines says, but I have suffered. So at least I must say that a careful retina examination is must before cataract surgery. Now, I would conclude with a good quote from Warren Buffett that it's good to learn from your mistakes, but it's better to learn from other people's mistakes. I thank you everybody to have been patient in listening to my presentation, and now I hand over the baton to Dr. Anaga Hirur from Mumbai so as to share her screen and then give her presentation. Thank you everyone.
Thank you so much, Dr. Mohit. That was an excellent presentation.
Thank you.
Lovely, lovely presentation. I'll just share my screen.
Welcome, Grover, sir. Dr. A.J. Grover has joined us to bless us here. That's great to see you, sir.
A very good afternoon, everyone.
You.
Namaste, Dr. Grover, sir. Very nice to
How
see
are
you.
you? Nice to see you.
Yes, yes. Thank you so much, sir. Are my slides visible?
Yes, yes,
Yeah.
carry on.
Yeah, and am I audible?
Yes, very much.
Yeah, okay. Thank you so much. At the outset, I would like to thank Dr. Mohit for including me in this IC, and Dr. Dilpreet Singh also. Best wishes for his relative. And today I would be speaking to you all on how to avoid biometry errors. We've already seen how we need to be more careful in our clinical examination so as to prevent any errors in the pre-operative phase. The next most important step is the biometry, and today we need to see where are the sources of error and how we can avoid it. So the errors could be in measurements of keratometry or axial length, and axial length is more important than keratometry because the quantum of error gives rise to a greater margin, and that is why we have to be extra careful, but both of them are equally important. IOL formula errors, there could be manual errors of maybe mislabeling an IOL, or transposition errors, or taking up the wrong patient with the wrong name. There could be special situations like extremes of axial lens, posterior staphyloma in high myopia, post-refractive surgeries, and post-silicone oil, which we will be all touching upon. So in the preoperative biometry, what we want to target is extreme precision and accuracy in all these areas. Now, when you're talking about keratometry, we may use an auto-K, we may be using optical biometry, topography, and pentacam also in specifically in premium IOL patients like toric IOLs and multifocal IOLs. What is important is to know that not all K readings are equal. So you may not be able to get the same reading in every instrument, but we need to correlate and see that they are correlating and repeat the measurements so that you get reproducible measurements. The closer you go to the center, the more accurate is the reading. You may have different readings and different measurements from different instruments because the place and the point at which they measure is different. So there are a few tips. So first of all, your machine should be calibrated and you should check for its accuracy. Use a dedicated single instrument that is known to be accurate. Most of these cataract patients may be dilated already when you see them. See that you do a biometry on a virgin eye before any kind of dilating drop or anesthetic drop has been put in the eye. Ensure that the patient has a good tear film. There is no ocular surface disorder. Take an average of 3 readings, including the axis. So if there is a very flat cornea or if it's a very steep cornea, then it's best to be rechecked by another technician. In case the keratometry is less than 40, be sure to ask the patient about history of refractive surgery and do a topography to look for any central flattening. Repeat if the difference between the two eyes is more than 1.5 diopters. I would say even 1 diopter. And if there is a scarred cornea, use the fellow eye or average the results and correlate with topography. Like for example, here we have a patient with pterygium. You can see the ring image is also distorted nasally. And there is a flattening. You can see the triangular flat area with raised horizontal coma and horizontal trefoil on corneal wavefront. Now, these are patients where you would get higher astigmatism, where you would get higher order aberrations. So you need to treat the patient first with pterygium, wait for a few weeks, at least 4 to 6 weeks, see that the keratometry is stable, the topography is stable. By that time, the astigmatism also would have reduced, and then only go ahead so that you don't end up having biometry errors. You could have a patient with ocular surface disease having a dry eye, and that could give rise to changes in your keratometric reading. Now, you may use either ultrasound or biometry, but remember that optical biometry scores over either immersion, and that scores over a contact A scan. Now, what are the advantages of optical biometry? Definitely, it is more accurate because it avoids operator variations. It's a non-contact method, and that is why it eliminates the chance of a corneal compression, which could be possible with an applanation A scan, and it measures to the center of the macula. We'll see in the next slide how it is different. So here to the right, you have the IOL master, which measures up to the RPE, whereas with the ultrasound, it will measure only up to the ILM. So there is bound to be a little difference in the axial length also. The A constant is going to be different in both the ultrasound as well as IOL master. So be sure to check the IOL power depending on what mode you are going to use. Now, if you're using an ultrasound biometry, remember that there would be an accuracy of 0.1 millimeters. The values would be slightly longer with the immersion compared to the contact method. So how will you know whether your A scan is perfect? So basically, you will know if your A scan is perfect if these lines are perpendicular. Like for example, you have equal height double corneal peaks here. You have 5 sharply rising echoes like this. Then you have the retinal spike, the scleral spike, and then the descending orbital fat. And there is a reproducibility in these readings. Now, gone are the days when we were doing the contact A scan. That should be definitely avoided. Immersion could be done, but optical biometry is always preferable. But in cases where even the swept source OCT of the IOL Master 700 may not pick up, just in say 10% of cases, we may still need to depend on the immersion biometry. So what are the potential sources of error if you're using still the contact method? Remember, if 1 millimeter of corneal compression can give rise to a large error, and longer the eye, you may get a 1.75, and shorter the eye, you may get as high as 3.75 diopters. So definitely that needs to be taken care of. There could be other sources of error like fluid excess, misalignment, poor fixation, and you may choose an inappropriate eye type. So some common errors are if the beam is not perpendicular, then you can see that the retinal spike is not perfectly straight. If it is not through the center, you can see that the posterior lens spike is short. If it is misaligned along the optic nerve, then see whether the spike is absent here. Also, you could have air bubbles in the fluid in case of the immersion method, or you may choose an inappropriate eye type. The use of individual sound velocities may be more accurate. Also, remember to choose the right mode if you're choosing a patient for secondary IOL like aphakia or an IOL exchange with pseudophakia. And in case of a pseudophakia, remember to choose what kind of lens was used when you're doing an IOL exchange. Now, we all know what is gain, and a lower gain setting is used to improve the resolution of spikes, but errors can occur with a very high gain and with a very low gain. So we have to be very careful. In cases of very high myopia, you could have a posterior staphyloma that causes an irregular shape of the ocular wall. There is a no distinct high retinal spike seen, and they could give rise to a significant error. So optical biometry is definitely better because that would go along the visual axis. So here again, as you can see, this is the source of error because the deepest portion of the staphyloma may be located eccentric to the macula. It's always best to correlate with a B scan and use an appropriate IOL formula in these cases. You may have macular lesions like a retinal detachment or irregular edema, or any elevated macular lesion will cause a problem and a shortened axial length measurement. There could be vitreous lesions like either vitreous hemorrhage or asteroid hyalosis or a gas bubble again, which can give rise to an error. Now, in case of patients with silicone oil, remember that the sound velocity in silicone oil is lesser, and this low sound velocity can result in sound attenuation and difficulty in identifying retinal spikes. And hence, ultrasound biometry is bound to show errors. This will be less affected in optical biometry, and that is the procedure of choice in these patients. So some tips for accurate measurement of axial length. Again, ensure that the machine is calibrated. Check for the correct velocity. Gain should be set at lowest level, which will give you good resolution. Average of at least 5 to 10 consistent results, and look at the lowest standard deviation. Again, in case of some ointment which was put in the eye or a lubricant, then it could give rise to an improper tear film. Now, sources of error with an incorrectly short measurement. Again, there are a host of reasons why, and you have to be very, very careful, like what we have already discussed. Again, an incorrectly long measurement, again, like I said earlier, an air bubble or a fluid bridge, gain set too low, posterior staphyloma, or a misalignment of the sound beam. Now, coming to optical biometry, definitely IOL Master 700 has given us much more better readings, more accuracy, and in more number of patients, even in greater degrees of cataract. But the fixation has to be good. In patients with poor fixation or incorrect alignment because of low vision, nystagmus, blepharospasm, or strabismus, we could still have errors. Again, if the surface or the ocular surface is not right, then these keratometric readings can be incorrect. For example, the position has to be right. Now see, if the position is right, here we are looking at an astigmatism of 1.48 at 105, but if there is a tilted position which the technician may miss easily, it can give rise to an error. Whereas here now what you are getting is 1.56 at 83. So if you are planning a toric IOL, you can easily go wrong. Again, if it's a patient with silicone oil, remember to choose the mode of silicone oil. Here you would get a biometry of 25.5. If you have chosen just a vitreous body, it would be 22.5. So you can end up in a refractive surprise. Personalization of A constant is absolutely essential. Why do we personalize? Is because we need higher precision and higher accuracy so as to get best visual outcomes. IOL formula should be chosen according to the axial length that is of the patient. Barrett is a very good formula to be used. In very high myopias, be sure to have better accuracy. You can have other also. Then just going through certain other special situations in keratorefractive surgery, you have ASCRS online calculators, IGIS-L, Barrett True-K. Remember to choose the right formulas. In post-keratorefractive surgery, the keratometry would be fallacious because of overestimation of the keratometric reading, leading to hyperopic outcome. In RK, you have a smaller central optical zone and a lot of variability in the readings. In LASIK, it's the change in the back to front ratio, and that is why there could be a lot of error. For example, just a last case, this is the central ablation post myopic.
Sorry to interrupt, ma'am.
Yes, just finishing in 30 seconds.
The time is up, yeah.
Yes. So this is the ASCRS post LASIK calculation, which is showing 12.5. What we used was 12.5. With an IOL master, if it is not considered as LVC, you would get something as 10.5, which would lead to an error. A Higgins suite will give you 12, so it gives you good results, and the Barrett suite also. So be sure to use the right formula. Repeat keratometric reading if the keratometry is showing changes between the two eyes, axial length is less than 22, more than 26, difference of more than 0.3 or a prior keratofractive surgery. Correlate the vision with the axial length and be sure also to take good history, calibration, correct technique and slow down. Tell your technicians to be careful. Thank you so much for your kind attention. Thank you.
Thank you, ma'am. That was wonderful and very much informative. So, thank you, Dr. Anaga, for sparing time and being with us in the
Thank you so much.
introduction course.
Thank you.
And that
Thank
was
you.
great. And now I would like to invite Dr. Sudhir Srivastava from Lucknow to give his presentation that how his technique sometimes went wrong to result in an unhappy patient, and he is now kind enough to take up the talk of Dr. Dilpreet Singh also. So he would be taking two presentations back to back. He will be giving some surgical insights and then also giving inputs on how to do a perfect toric IOL. That's how it goes. Welcome, sir.
Just a minute. Is it visible? Mohit,
Yes, sir.
my slides are visible?
Yes, yes, yes.
The voice is also clear?
Yes. Perfect. Go
Okay,
ahead.
thank you. Good afternoon, everyone, and I must thanks to Mohit and Dilpreet. Unfortunately, Dilpreet is not with us today, and I wish all the best for his father uh, health. And uh, I way thanks to AIOS for giving me this platform to talk about. And today I'll be talking about the unhappy patients after phacoemulsification. Where did I go wrong? As you all know that the phaco is the gold standard for the phaco surgery, cataract surgery nowadays, and since its inception 1971 we have gone a long way. We have come a lot of innovations have come up, and phaco is the gold standard for cataract surgery nowadays. And now we are more talking about the quality phaco surgeries, and satisfaction has gone very high along with the expectation of the patient. So today I'll discuss how to make our patients happy, because if the patient is happy, that definitely will be happy. What are the reasons for the unhappiness? Obviously the patient comes for the cataract surgery because of the visual gain. So if the visual gain is not there, if we have not done the proper visual axis alignment, maybe the IOL might not be there in the proper way, the biometry was not accurate, the position of IOL is not proper, so patient may complain. Though obviously the patient will not be happy and he'll complain. And sometimes we'll get the discomforts which are not related with the visual problems, but maybe related with ocular surface problems, irritations, or discomforts, or watering, or related with the eye will problems like dysphotopsias, and positive or negative dysphotopsias, and other halos, or so on. So happiness comes when we do ethically good, when we do the best of surgical practices, we do proper surgical steps, and obviously we must try to gain the trust factor, because that the trust factor is lagging behind these days, and because of so much of the negativity towards our medical fraternity. So we have to fight with the trust factor also. We have to talk to the patients in the pre-op and post-op also. We have to explain everything. Even if the complication happens, we have to take the patient under confidence. So raising the trust factor is also very much needed to raise the happiness index. So now directly will come, because the time is short. So just a minute. Yeah. So as you all know that in the modern surgery, the fake capsular axis is the biggest inventions. Without capsular axis, we cannot think about doing good phacos. And previously, when we started our phaco surgery, the size and shape were not important. But now, because we are using a lot of premium IOLs, we are using toric IOLs and multifocal IOLs, where the centration is good. Even the monofocal aberration-free IOLs, if we gain the best from the IOL, we must have the properly centrally placed IOL. The size and shape are very important. We must keep the size of rhexis around 5.5 to 5 millimeter, just to give the good grip of the IOL. If the size of rhexis is bigger, then obviously the chances of PCO, early PCO formations are high. And if the size is less, then what happens, like in this video, you can see that I have released the phacophimosis, especially in the younger age, where the capsular wells are very active and the fibrosis happens very fast. So you have to be cautious to maintain the proper capsular axis size to achieve the best outcomes. And if your rhexis is compromised, especially in the cases of mature cataract or intermittent cataracts, where the capsular tone or the lenticular pressure is very high, so we may get Argentinian flag sign if we are not taking proper care of our pressure gradients. So if you are a standalone surgeon, my request is that convert the case, finish it with the SICS or the ECC. Do not try to bring your ego in between. And because if you want to continue with this and without any vitreoretinal support, then you may end up in a major complications. And request is just to simply convert the phaco surgery to any simple way, and you can just remove the nucleus and leaving the eye in a better way. And if you want to continue, if you have a vitreoretinal backup, then if you wish to continue, then you have to be cautious to maintain the antechamber pressure gradient well, because any sudden decompression of antechamber might extend the rhexis, the torn rhexis towards the posterior capsule. And if for phaco surgeons, we have to be well versed with the different types of problems. Like if the patient has a subluxation of lenses, then you have to well versed with the endocapsular rings. You have to keep all these such gadgets standby. And if you doing, and you should try to learn these techniques from your seniors, or from where, and you can learn. You must learn, and you always try to maintain the inventory. And in cases of problems where we need to implant multi-piece, I will always keep the stock of multifocal IOL, because it is not advisable to implant the single piece IOL, because they are thicker in the sulcus, because they are thicker, and they may create a lot of post-operative complications even in the secondary glaucoma in the later post-op period. As you all know, that Descemet's is very important, and it's an important structure to make the cornea in a dehydrated state. For the clarity of cornea, we need to have a good Descemet's membrane. And if your wound is not proper, if you're not make the proper size of the incision, then the chances of Descemet's tear are high. And if you're using blunt instruments, blunt blades, then chances of this detachments are high. It is very important to recognize the detachments very early, and you try to sort it out. If you can, if you have a recognize the thing early, then obviously you can by just simply putting the gas, the air, or if needed, then the long-standing gases can settle down. You can take the help of those things to settle the Descemet's early. Now, if the IOL is chipped, because what basically we want to achieve is metropia, and that is not possible without the implantation. So implantation is necessary, and we need to have a clear corneal, clear IOLs to achieve a better vision. So to avoid the chipping, it happens, and it happens more with the hydrophilic implants. So try to learn proper loading techniques so that you can minimize the such complications. If the haptic is broken, if you're implanting the any premium IOL like toric or multifocal, there is no choice. You have to explant the IOL, go with the fresh fresh implant. If the chip is minor, or if it is periphery, like in this case, you can see the chip is towards the periphery, you can leave the implant. Even if the chip is at the center and it is minor, you can leave the implant, and later on in the post-op period, you can assess the performance of IOL, and you can decide whether to go with the IOL, or you have to explant it. PCR is the most common complication. None of the surgeon can say that I am not well versed with the posterior capsule complications. It happens with every hand. Any day it can happen. And the detection of early PCR is very important. That is key to success. So detect PCR early. Do not try to do fishing. Do not try to go in the vitreous and pull it because your traction can create peripheral retinal detachments, and later on you can get a lot of complications. So your minor complications might turn up in the major disasters. So for every phaco surgeon, you must learn anterior vitrectomy, because this is the time of the need. You cannot uh, mild to moderate complications you can handle by yourself, and must learn to recognize the vitreous, especially for the youngest. It is difficult to recognize sometimes the vitreous and the viscoelastics. So try to recognize, and you can even the take have the triamcinolone on other gadgets to highlight the vitreous. Again, the small pupil is the main problem, especially in the older age senile patients. They have a fibrotic meiotic pupil. So you must have all type of expander devices. You must be well versed with the implantation of such devices and techniques. And if you want to continue with the even a moderate size, if you have that much of experience, always you can do it, but with the patience and by controlling your nerves. If there is a vitreous in the wound, so again you have to recognize the vitreous properly, and then do vitrectomy properly, because any kind of vitreous strand present in the at antechamber or in this wound can create a lot of traction in the peripheral part of the retina, and it can lead to, and even it can act as a nidus for the infection in the post-operative period. We may get endophthalmitis, chances are very high, and the traction can also lead to the posterior macular problems like cystoid macular edema and so on. So list is long, time is less. So learn good ethical practice, because good practices are necessary. You must learn the good steps of phacoemulsification to minimize the complications, to make the patients more happy. And because if you are doing surgery, you must have to face the complications. So but the important thing is to recognize them early and accept them. And if you want to take the help of your any colleagues, like if there is a drop, then do not hesitate to contact with the vitreoretinal surgeon. Take the help of vitreoretinal surgeon, so that you can achieve the best for the patient, and always communicate with the patient well. So in the post-op and pre-op period, like Mohit has said, that the communication and the counseling is very important in pre-operative cases. And Dr. Agna has explained that the way of keratometry, the head of posture of a keratometry can your IOL video. So I think with this I end, and I must convey again thanks to Mohit for having me. Over to
Dr.
you,
Sri,
Mohit.
you can continue with the toric inputs for in place of Dr. Dilpreet.
Okay. So, Mohit, because this was just told me, I think 10 or 15 minutes before the commencement of this program. So I just tried to, gather some videos of my. So I one of a video which I finished this did surgery in I think yesterday. I'll try to show this, and I kept two captions. So again, I'll leave my thing, which is the best eye for the toric. For the toric, where is the noise? Noise is coming.
We can hear your voice.
Okay. So, which is the best eye for toric? So, in short, any regular toricity, regular astigmatism is the best case for the toric. So, always do the topography well. If there is irregularity on the cornea, it may be in form of some ectasias, some corneal opacity, or some sort of keratoconus patients. So if the astigmatism is irregular, if you're getting the both irregular both side pattern, then the patients are not good patients for the toric IOL. So for the best toric, you need to select the regular astigmatism. Now, which marking system is the best? So there are a lot of studies have come up which have compared the digital marking systems and the CTM marking system, or even the we use dumbbells or bubble markers. So if you are doing in a right way, any type of manual marking systems are equally good if you compare with the any digital systems like Varion or Callisto. If you compare, several studies have already proven that your manual systems are managed well, you can achieve that almost that the level of your uh, marking goes almost same as the digital system. And as you all know that the digital system are pretty expensive and you need to invest a huge amount for those systems. Now again the size of capsular axis. Size of capsular axis, as I said in my previous presentation, is very important because here for a good grip you need to have 5.5 to 5 millimeter of capsular axis so that your eye will gets good grip all around, and the chances of rotations and chances of tilts would be quite less with a good grip of capsular axis. Phaco technique, whatever is comfortable. It depends on the density of nuclear cataracts. It depends on the variety of cataracts. Like if the patient has polar cataract, then you have to do accordingly. So technique is surgeon dependent, and it depends on the variety of cataract. Now you can see the good size of capsular access, and you can see polishing the posterior capsule with the hydrojet technique. Now best OVD. Best OVD, uh, especially in the toric, would be the high viscosity viscoelastics, especially the hyaluronic acid products, because you can easily remove them, and very easily they come out. And because any amount of viscoelastics left behind the IVL would be a reason for the early rotation of the IVL. So the best OVD is um, high viscosity viscoelastics. So again, load the IVL properly, inject the IVL in the bag, and thorough removal of viscoelastic is essential. Always go behind the IVL and thoroughly clean the visco behind the IVL, and then go anteriorly and wash all OVDs from all corners of uh, anterior chamber. And I think this is the one of the commonest reason for early rotation of toric IVL. Now, how much pressure we must leave before closing? So there should not be much of the pressure left in the ND chamber, because if you leave very tight eye, sudden decompression can lead the rotation of IVL in an early phase. So your pressure should be gentle. It should not be high, or it should not be too low. And after finalizing your when you just before finishing your surgery, before hydration, always press the IVL posteriorly so that it sticks well with the posterior capsule. So these are the few steps. If you take these steps properly, and if you consider those steps properly, definitely we can get the best outcome from the toric IVLs. Thank you very much. Over to you, Dr. Mohit.
Thank you, sir. It was great. That really shows how meticulous and how gentle surgeon you are. And hats off to your video recording things also. So that's great. And you have an IC on video recording that automatically says that how much you are into it. And we keep seeing you on YouTube. So now you are a YouTube surgeon also. So that's great. From India, you are getting laurels across the world. So that's a great thing from you. So Thank you once again. We have some time left, so that would be great if we will be interacting thereafter for some discussion on these IOLs. It would be now high time to invite Dr. Manish Mahindran, the director from Khairabad Eye Hospital, Kanpur, to give his valuable inputs on what should be the choice of IOL for a perfect cataract surgery. Because many a times the surgery went well and everything goes on well, but the choice of IOL unnecessarily, jeopardizes the result. So over to you, Dr. Manish. Welcome, sir.
Am I audible?
Yes, Dr. Manish.
Yeah, thank you. Thank you, Dr. Mohit, for giving me this opportunity to be with all of you. It was, we had some wonderful talks, and we are missing Dr. Dilpreet Singh. Unfortunately, he's not with us. His father is ill, and so he's taking care of him. So we wish all the best, and we hope that his father recovers soon. So moving forward, I'll be talking on the wrong choice of intraocular lenses, and I'll be dealing with a couple of my cases here. So this was a case of a 35 years old male and who had a history of retinitis pigmentosa with the NS grade 2 plus with posterior subcapsular cataract. So we did an uneventful phaco in this patient and implanted a hydrophilic lens which went in the bag. So this patient comes after 4 years, and what we see here is an anterior dislocation of the bag in the anterior chamber, as you can see here. So what went wrong here? So as we all know, like since I was dealing with the case of retinitis pigmentosa, now these have weak zonules. They have progressive zonulopathy, as in cases of pseudo exfoliation syndromes. And so with time, in these cases, the capsular phimosis occurs because of the unopposed capsular bag fibrosis. And later on, you may end up getting a late IOL subluxation or a dislocation, which can be anteriorly or posteriorly. So as you can see here, the whole bag, it came in the anterior chamber. So we enlarged the wound here, and I had to remove the lens along with the bag. You can see here the lens is entangled in the bag. So I'm now removing the bag from this entangled lens. And you can see here the shrunken bag. So this was followed by an anterior vitrectomy, and then an anterior chambered intraocular lens was implanted. You can implant a scleral fixated lens or a glued IL in these cases. So what went wrong here? Wrong choice of IUL. We used a hydrophilic acrylic intraocular lens. Well, single piece acrylic lens are easy to implant and they avoid additional stress on the zonules, but they don't resist the capsular contraction syndrome. So in this case, actually a 3-piece IEL would have been better. It is larger, it is rigid lens, and it prevents capsular phimosis. So we should have implanted this lens. This is another case of a 36-year-old male with a posterior subcapsular cataract with a high K readings. And I implanted a toric IOL in this case, and I got a surprise. Now, when we did topography in this case, we noticed that we were dealing with a case of a keratoconus. Therefore, IUL calculation and selection is very, very important in these cases. We know that we are dealing with high amounts of irregular astigmatism in these cases. And therefore, for moderate or low-grade keratoconus cases, you may go for a toric intraocular lens, but if it's a little advanced and when they have irregular astigmatism, toric IOLs don't work. So what happens is here is that the visual axis is not at the apex, but at the slope of the cone. And therefore, the readings that we get, the keratometric readings that we get is only of the central or the paracentral area. And so we can miss out on the actual K reading. And therefore, IOL power calculation is difficult in these cases. Also, what we can do here is, like, if you have an optical biometry and you do an IUL master, always look for the standard deviation of the keratometry. When you do an IUL master here, you see these values, the SD values, the standard deviation values. Now, if it is more than 0.20 diopters, which is expressed as a 0.03 millimeters, if it's more than 0.03 millimeters, then it means that we are dealing with an irregular astigmatic patient, and therefore we need to do a corneal topography in these cases. Another case was a 76-year-old male who had a mature cataract and a senile miotic pupil. This patient wanted a trifocal implantation, so we went ahead, did an uneventful phacoemulsification, implanted the lens in the bag, and what we get is a poor near vision. The patient was very unhappy post-operatively, and then we noticed that he had a miotic pupil, as you can see here. Now, what happens here is, when we are dealing with the trifocal lens, the central zone has the refractive zone, while you have the peripheral diffractive zone, which is mainly used for near or intermediate vision. Now, when you have a myopic pupil, the iris covers all the diffractive zone, and you are left with only the central refractive zone, which is for the distance vision, and the near intermediate vision is compromised. So therefore, the patient is unhappy, as he is not able to see for near vision. This is another case of a 52-year-old male who had undergone LASIK 18 years back, had a grade 3 nuclear sclerosis cataract. We did optical biometry, and which turned out to be an IOL power of 15 diopters. We went on straight ahead and implanted the lens, and we got a post-operative refractive surprise. Patient had the post-operative hyperopia. His unaided vision was 660, which improved to 6.6, but with the refraction of +3 diopters. So what actually happened here? Now, what happens is that when we do a LASIK or a PRK, what it affects the anterior corneal surface. So the anterior corneal surface changes, but the posterior corneal surface remains unaltered. So there is an anterior and posterior, power ratio shift, and the cornea's effective refractive index has been altered. So therefore, we will not able to get a true K value here. So in these cases, what happens is that when we do the myopic correction, the corneal power is overestimated, and the IOL power gets underestimated. So we get a post-operative hyperopia, and that's what happened in this case. So it's very important to collect all the pre-operative data of the patient, analyze the corneal map. If you have devices, go for a ray tracing where you can see the corneal asphericity, post-corneal astigmatism, the corneal aberration, and always under-promise these patients. Always under-promise and over-deliver these patients. You can also use the Iul Calculator here, the ASCRS post-refractive surgery Iul Calculator, where you have to fill in all the data here. If you have a pre-LASIK refraction, the keratometry, then the post-operative refraction, keratometry, the K values, the ACD, the axial lens thickness, white to white, all these, whatever data you have, you just put this inside it, and then you will get an estimated IOL power, which will help you in getting these post-operative surprises. This was another case where we did a phacoemulsification, and then PCR occurred, and we implanted a single piece acrylic IOL. Now, sometimes you don't have those 3-piece lenses in your inventory, and then things can become very difficult. So we implanted this acrylic lens, and when we saw this patient post-operatively, we saw that there is a sunset sign here. Now, in these cases also, hello, now, am I audible? Now,
yes.
Okay, so now in these cases, what happens is, since these IOLs can get decentered, and if you look at this picture, the haptip rubs the posterior pigment surface of the iris, and which can lead to uveitis, glaucoma, hyphema, the UGH syndrome. So the good choice would have been a 3-piece IOL in these cases, as the optics overall, the size of the lens is big. It centers well in the sulcus, and the haptics, they are angulated in such a fashion that the optics don't rub the iris, and you can even go for an optic capture here, where the lens can be well stabilized. So a 3-piece would have definitely be a better choice. Another case scenario where he had a 48-year-old male who was myope, had a nuclear sclerosis of grade 2, and prior to cataract surgery, his refractive error was -2 diopter, and we did a biometry and then implanted a monofocal intraocular lens in this case. And the patient was absolutely miserable after surgery. He had complete loss of accommodation, and despite of him having a vision of 6.6 and good vision for near with the +2.5 diopter, he was not happy. And when we explained the patient that he just has to use glasses for near, he said that it's really weird because I have never used glasses for near all my life. It's for the distance that I've been using glasses, and for near glasses I have not used glasses, and now you have done the reverse. So it is important to treat every patient individually, discuss with the patient, provide the best possible vision to the patient. For these myopes, you should overcorrect the IOL power to slightly make them myopic so they are good so that they can read without their spectacles. You can even go for the presbyopic correcting IOLs in these cases. So it's important to give time to the patient and get to know what he really wants. And I would like to highlight here another case that this was when we are doing multifocal intraocular lenses, it's very important that we should implant the lens right in the center, and it should be in between the visual axis and the center of the pupil. Now, if you understand this diagrammatically, you see here, now we have this visual axis, which is a line drawn from the fixation light to the fovea. And then we have the pupil, the center of the pupil. And if we draw a line perpendicular to this center, we get the pupillary axis. So the angle between the visual axis and the pupillary axis is the angle kappa, which is actually very important. So what happens is, now, if you look at this diagram, you will find that in the center, you have the visual axis here, and then the center of the pupil here. So the intraocular lens, the center of the trifocal should be in the center here. And you can also get this kappa value when you do an optical biometry. Now, if you look here, when you do the white to white, when you see the white to white values, down below is a value, is the kappa values. You see the px and the py. When you add px and py, it should be less than 0.6 millimeter. If it is less than 0.6 millimeter, that means that this patient is good for a trifocal lens. And then the patient will not have halos or glare. But if it's more than that, then this patient is, you should avoid putting a trifocal lens in this patient, as he may complain later on. So to conclude, it's important to do a proper surgical evaluation in all our cases. We really need to plan our surgery carefully. We should be very diligent and skillful with our surgical techniques, and always give time to the patient. Choose the proper IOL which is to be implanted. Maintain your inventory, so that, because once you have started off the surgery, there is no going back. So you should have all the lenses that you require, and you should put the proper IOL. Thank you.
Thank you, Dr. Manish. It was a really very informative presentation, and you raised very fine points so as to be considered before we choose the IOL for our precious patient. So despite of very skilled surgeon, despite of huge finance being put, but some wisdom has to be there when we choose the IOL in order to give a good perfect result. So now we have the teacher of teachers with us. We have Dr. Ashok Grover with us. Sir is chairman from the Gangaram Hospital, and none AIOS is there who can say that who doesn't know Dr. Grover. So no need of any introduction. Namaste, sir, and good to seek your blessings here. And we thank you from the core of our heart that you are a part of our instruction course. Over to you, sir.
Thank you, Dr. Mohit. A privilege to be a part of this group. I've really enjoyed this session and really learned a lot from everybody. I was a little delayed because there was a board meeting and I was on the way. That's why I kept my screen off and reached home by 3:30. So thank you very much for inviting me to be a part of this. Missing Dr. Dilpreet and wishing very speedy recovery to his father. So communication errors form a very important part of the reason why some patients may be unhappy. And this has been highlighted by several speakers. Dr. Manish spoke about the myopic patient who was unhappy because he no longer could see for near as he has always been doing, or the trust deficit that was referred to earlier. So all these aspects form a very, very important part of patient satisfaction. So let us look at communication. Let's first see what communication implies. So when we talk about communication, what is important to see is that it is imparting or exchange of information, both by speaking, writing, or any other medium. So there are multiple media involved. The communications, verbal is an important aspect of it, as we all know, but the non-verbal aspect of how we communicate is equally important. How much attention we give. Do we have eye contact when we talk to the patient? And do we do that occasional encouragement or patting or hugging to our amma to really build that confidence, which is becoming a difficult and problematic thing these days. So that is again a two-way exchange. So as in any other communication, it is important to hear what is not being said. The body language of the patient is important, and body language that the surgeon or the entire team has, that is again important. So what does the communication do? Communication helps us better understand people. This is the most important thing. And it helps us build trust and respect. So these two are some of the most important aspects of communication, which we all do in our own ways, in which we deal with patients, in the ways we have taught our teams to deal with the patients. But when we understand the importance of this, we do it better. Again, empathetic listening is very, very important. Listening is the key to communication. Now, what this quotation says, the biggest communication problem is we do not listen to understand what is being said. We are listening because we are getting ready to reply to what is saying, framing our answers at that time. And we are missing out on some of the other things that are being said while making a statement which may not clearly be stated. So now coming specifically on to what communication needs to be with a cataract patient, we can consider it as preoperative, intraoperative, and postoperative communication. But again, emphasizing lack of communication is what leads to a lack of trust, which leaves room for doubt and creates the problems. The preoperative communication is not just what our people, our staff, and we speak. It is a lot to do with the rest of the things as well. The ambience, whether it appeals to the patient in terms of being caring. It doesn't have to be lavish. It doesn't have to be 5-star, but it appears caring, where the people are attentive, people are willing to help. That kind of ambience is important. The displays all around, which may talk about the surgical techniques available, the intraocular lenses available, and the choices in different kind of situations, they may all be important in communication, besides, of course, what we as individuals deliver to the patient. So the communication is at the front desk, is by the optometrist who does the workup, the communication by the surgeon, and by the counselor that most of us have. So the communication preoperatively should do a very important thing of understanding the patient You need to understand what his occupation, what his professional requirements may be, what his specific visual requirements may be, as we were talking about that myo. We also need to look at the personality of the person and deal with him accordingly and see whether he's an over-demanding patient. You also need to see amongst the attendants who's the decision maker, whether the patient himself or one of the attendants is the decision maker. And his background and relationship with the patient also make a lot of difference to how the decisions are made. So what we need to communicate includes not just the nature of surgery, but nature of disease, options in management, what preparations need to be made pre-operatively, nature of surgery and experience during surgery, post-operative expectations, and financials. So of course, the important key is to communicate in a very simple, easy to understand way. And as Albert Einstein said, if you can't explain it simply, you don't understand it well enough. So you have to have the depth of knowledge to be able to communicate in simple words. Consent is a very important part, but informed consent has to be very specific, very detailed. It has to be individualized for each surgery. And of course, appropriate documentation is the key. This has been emphasized in several talks today. Under promise, over deliver. If you ever promise the moon, the patient will definitely be disappointed. It is also important during the surgery to put the patient at ease with reassurances, explain the likely experience, explain what you expect the patient to do, and a word of appreciation during and after the surgery. These go a long way in building the trust and a relationship of mutual support. The communication should also be post-operative with regard to his experience and discomforts that he may have, post-operative precautions that he needs to have, and some of your staff, if they inquire about their welfare telephonically, goes a long way in enhancing the patient experience. And availability of one of the staff for SOS calls or difficulties that may arise. Now let us look at, we've looked at what the communication should be. Now let us look, where do we go wrong? One of the major things is that we don't develop that relationship. Our communication, even if we are very busy, amongst the staff, there should be somebody who's communicated enough to build a relationship of trust. Second aspect is inadequate assessment of patient's personality, his expectations, his requirements, which is very important. And if we do not give adequate information on all aspects. Also, the patient, if he expects post-operative chair time, that needs to be given to him. So if these are the 4 areas that are taken care of, then we generally would have a relationship which would go a long way and would not result in unexpected legal challenges and so on. But the biggest bugbear often is unrealistic expectations, which again goes if we understand the patient and if we do not overpromise. So let's look at all these. So developing that trust or developing a relationship can be a long-term thing. The patient and the family have been coming to you for a long time. They've seen that your dealings are trustworthy and uniform to everybody, and you give them enough time to develop that trust. This aspect, again, we have dealt with that. This includes his personality. His expectations are directly dependent on his nature, which you can judge during the meeting, and from the kind of experience that he's had earlier in his previous eye or anything else, which tells us what the patient's demand, what the patient's expectation at the end of the surgery is. Whether he would like his astigmatism to be corrected, whether he would like and unassisted near vision or not, those things need to be assessed adequately. This is very easy explanation. Information needs to be as complete as possible, including possible complications, and just the written complications do not suffice. When anything happens, the patient would definitely say that he needs to have been explained this better. So as we say, the single biggest problem in communication is the illusion that it has taken place. Sometimes we assume that this is understood, which doesn't happen. And this is what George Bernard Shaw said. So don't ever assume that this goes without saying and this the patient does understand. We must state out all the things. And nothing helps more than post-operative explanation and chair time. So to conclude, appropriate communication is absolutely the key to having patients who will trust you, who will remember you, who will come back to you again and again. Thank you very much.
Thank you, sir. That was really great once again, as usual, and we really appreciate this kind of presentation is usually always there from a person who is experienced as you are. So that was great to have these words from you, and this is what we were desiring, and you have delivered once again. Hope the
Okay.
audience enjoyed, and we have some good 10-15 minutes with us to have the remaining discussion. So if anything we want to talk with each other or raise question, then definitely this is the time. We have Grover sir with us. Anybody? I personally want to ask, sir, if a complication happens, and complication now has happened, and the next day the patient is with us, say endophthalmitis, if it has happened now. So what would be the best way out to tell that what has happened and how to go about with it?
One, you have to be very caring of the patient. And you may be requiring to take give him special time, extra time, taking that extra care to explain to him things, spend more chair time with him. But at the same time, the second important aspect is not to feel guilty, because this is not something that you have done deliberately or that you have missed out something and it has happened. Complications, PC tear happens, nucleus drop happens. If we feel guilty, that gets communicated to the patient. So that is the second aspect. Absolute best care to the patient, look after him, give him special time, maybe see him at a separate time, but at the same time, be totally communicative, explain everything to him, but don't communicate by non-verbal means that you are feeling guilty. And that will only happen if we stop feeling guilty about it. I mean, these are things which will happen in best of hands. These are the things which will happen in spite of the best precautions anywhere in the world. So we should stop making ourselves guilty, making our lives miserable. You know, some of us can't sleep well. Some of us, like me, can wake up early in the morning, next morning, whenever I'm too tired, so I sleep early. But I'll wake up early if I've had a complication next morning. So we shouldn't be feeling that. That is what we have all to learn, and that should not get communicated to the patient by non-verbal means, which is what leads to their sometimes being dominant or going on to suing us.
Thank you, sir. Thank you, sir. Dr. Sudhir, I have a question for you, sir. What technique of nucleotomy do you suggest that everybody should learn as the safest procedure to get away with cataracts? One technique that everybody should master.
First, Professor, your words that non-communication is very important, because whatever we feel inside our heart, that communication with some life. Exactly, your comment about that not feeling guilty is very important, because you are surgeon, you have to face complications. So whatever complications you faced, you managed it. So the important is how you manage those complications. So do not hide anything, just communicate with the positive note with the patient. That is very important. And your question, Mohit, nucleotomy, I think for the beginner, I would suggest that every surgeon must learn the quadrant technique, because this is the way where you can actually assess the demography of that nucleus. Means you can learn about the how much thickness of the nucleus there, how much in the center, how much in the periphery. So about if you want to learn about the physiology of the nucleus, you have to be well versed in the uh, trench technique. So 4 quadrant would be good, and because I started with the 4 quadrant, then I shifted to single quadrant, and then now I'm doing vertical chops. Now I think it comes with the time, with the practice. That's the point. And I want to add one thing, Mohit. In your presentation, you said that about the OCT. I would suggest, and in fact, we are also doing. We have the protocol about uh, made the protocol that doing OCTs in each and every cases, whether we are doing premium IOLs, because every eye is premium for us. It is not that the IOL decides that which eye is premium. So every eye is precious for patient, and it is precious for us. So for every patient, if you are going for surgery, if you can see the retina, you must go for OCT. You must refer the OCT, because minor things, minor ERM, epiretinal membranes, or even the minor holes, you can detect very early. And if the patient has mature cataract, then you won't have any choice just to do simple B scan.
Dr. Sudhir, a question. Do
Yeah.
you do the OCT complimentary? Do you charge discounted, or do you charge as you would when you do an OCT?
Sir, normally when the patient comes for the surgery, if the patient is taking dates, if we have booked the patient and we are doing the means the B scan, then on the same time, if the patient comes after, means suppose we have diagnosed the patient and patient came after a week or 10 days time, then just before cataract surgery, every patient just before cataract surgery we always do, because even 24 hours matters. Sometimes patient was
As a part of the
not
same package.
not having any vitreous hemorrhage, and the day of surgery the patient comes with the vitreous hemorrhage. I think the best way practice is just to do OPD in each and every patient just pre-op of the patient when the patient is going.
My question was as a part of the package, no extra charges.
No extra charges for that, because that's for our safety, and it protects us also. So a lot of medical legal aspect, as the Mohit has faced in his case.
Yes. And it's very difficult to pick up lamellar holes or even full thickness holes through a grade 3-4 cataract, where the color is altered, shade, tint is altered. It virtually gets very difficult to pick them up.
Yes. One more thing I would like to ask Dr. Manish. People nowadays, most of the people say that I don't want to wear glass. I want multifocal lens, as they have heard maybe from the peer group or through internet or whatnot. So the audience and the general ophthalmologist should be conveyed that when not to put a multifocal IOL. So can you highlight on those issues that when a multifocal IOL should not be given to a patient?
Yes, Mohit, as I already mentioned in my presentations, like you see, if as the case was of a meiotic pupil, so in that particular case, a multifocal or a trifocal lens would not benefit that patient, as he would miss out on his or compromise his near or intermediate vision. So one scenario would be that. Another would be, a person having an astigmatic error. So anyone if has an astigmatic error of more than 1 diopter, then those patients, they are not fit for a multifocal or a trifocal errors. Although now you can plan them with a trifocal having an astigmatic correction along, but plain multifocal or trifocal lenses would not benefit. And also, as I if the patient has any corneal scar or any retinal pathologies of diabetic patients, suppose, and if you see subtle signs of NPDR changes, though in those cases also one should avoid putting these trifocal lenses. And also, if one eye has undergone a monofocal lens, And even if the patient is willing for a trifocal lens, you should explain the pros and cons of the surgery, and try to put a monofocal in that patient. Although there are studies now which have shown that a patient having a trifocal in one eye and a monofocal in other eye are satisfied, but then you should explain the patient about the pros and cons of the surgery. I think those are the points which where you can mention the patient.
Okay, that's great. Last question from my side to Dr. Grover and Dr. Sudhir both. So these days we are getting more and more number of patients of cataract who had undergone LASIK already. So in that case, even today, there is no foolproof method of a perfect biometry. And the patient has never been interested in wearing glasses from the age of 20. So they are the highest demanding class of patients in cataract. So what communication skills you would like us to speak those good precious words before we take up the case, and what IOL Dr. Sudhir would like to implant in these cases?
Exactly what you said, that there is no exact method of finding out the refractive lens for them, that they should expect some kind of a requirement of a glass later. Multifocals are definitely out. Torics are also often out because of the irregularity of the cornea, especially with post-RK eyes, most certainly. And of course, the power calculation was already pointed out very well, and that you use the Barrett True K formula, and you use the ASCRS website, complement both, maybe use keratometry with a pentacam, and do all those things. But at the same time, the communication is most important, that you are not going to get a zero refractive error, whatever best effort we may make. And this is the price you pay for having had refractive surgery at an earlier stage. We will do our best. This is what we need to communicate.
Very true, sir. Actually, like in your presentation, you said that illusion should not be there. You have to be real. Actually, such patients should be dealt very carefully, especially the communication. The pediatric period is very, very important. And we have to bring the patient's expectation to the reality. And we should explain exactly what is not possible, what is possible. And as Dr. Grover said, that multifocal is always out, and because patient comes with a lot of aberrance on the cornea. So probably if you implant a multifocal IOL, again you'll raise the patient's expectation, and again the patient will come with the complaint. So you have to bring the patient's expectation to the ground, and then you deal the patient. Definitely, your patient will be happy. Over to you, Mohit.
Thank you, sir. That was a great session, and I must see the clock now, and we have 1 minute left. So that 1 minute is there to say bye bye to each other, and let's hope so that the next AIOC we shall sit together in a room, and then sir has already promised of some hugs and some pats. So we will be getting them from sir, and then I look forward that we have a physical meeting next year. So I thank all organizers, the panelists, the audience, and Mr. Raj, who coordinated the hall so brilliantly. And special thanks to you, Grover sir, Dr. Sudhir sir, who especially dealt with Dr. Dilpreet's absence also. Dr. Manish, as always, was brilliant. And I thank everybody who spared time to be here with us today's afternoon. And I wish all the best and safe next year till we meet in the next AIOC.
Thank you.
So,
Thank you,
saying
Raj.
bye bye.
Thank you
Thank you
for
so
bringing
much,
us
doctor.
together.
Thank you.
Thank you so